to the Nigerian Society. And so one of the talks and things that I'm focused on is building a program, clinical vessel wall imaging program. And in that regard, what I try to tailor for this particular audience is not so much about innovation, but how to build a program and how to be focused about getting a subspecialty technique into clinical practice. And so with that in mind, I first want to start by saying that typically anything new, right? Forget about innovation, just any type of change, people have a resistance to. They're more comfortable with what is status quo. And so being asked to do anything new or change their processes is typically met with resistance, despite the fact that verbally everybody talks about innovation and how they're on the cutting edge of things. But in real life and in practice, I think that from day to day, people don't actually want to do anything that's different from what they're comfortable with. And so when I started building my program here at Penn, I was met with a lot of challenges because I was trying to change what they were doing by introducing something new. And so I'm going to talk about vessel wall imaging in that context, because when I arrived at Penn, it wasn't something that Penn was doing. It was something new. And getting that boarded onto clinical practice, I'm going to try to move. There we go. I think I was going to try to move this so that it's not covering, but I have 4 screens here and I'm a little bit confused how to do this. But anyways, so you'll have to bear with me. There. So as I was saying, vessel wall imaging was something new. And when I first started here, I first had to teach everybody what it actually is. So it's a pulse sequence, T1 weighted variable flip angle. This is actually a product sequence. And so on any vendors such as Siemens, GE, or Philips, it's actually readily available. It does need to be optimized. And what I mean by that is you have to optimize the parameters to suppress out the flowing blood intraluminally and then suppress out the CSF outside of the vessel. And when you optimize those parameters, then what you will see is the vessel wall in greater conspicuity, right? So this is not routine imaging. However, it is a routine product pulse sequence with a few optimizations that are readily available. When I first started here at Penn, this was just a concept, right? This wasn't something that was in practice. And I needed the pulse sequence itself. As I mentioned, it's readily available, but it does need to be optimized. And so I emailed a lot of people for help. Just to give you a little bit of background, I started my faculty position in 2018. So this is when I first started. I emailed a lot of people to ask if they could share their pulse sequence. And in 2019, I actually, from now a collaborator, but at that time, he was another author that I just read his work in MRM. I asked him for the PDF of this pulse sequence, and he kindly shared it with me. And then from 2020 and beyond, is when I did the program implementation, where now it's considered a center of excellence. That's taken quite a bit of time. You can see the last 5-6 years, I would say. However, I think it's been worthwhile because I've seen changes in how people are practicing medicine. So this is what it looks like. This is what vessel wall imaging looks like. This is the first paper that I read by Dr. Zhao Fan. He's actually also one of the ISMRM members. And Godwin, as I mentioned, he's actually now just started at UCSF in this past month. But I read this paper, I saw these figures, and I thought, wow, this looks beautiful. This is the type of imaging that I would like to bring to Penn. What I'm showing you here is a coronal MIP image where you're seeing the vessel walls themselves. Here in the yellow arrow, this is what a normal artery would look like. However, here in the red arrow, you can see this eccentric wall thickening and enhancement. And so this is what it would look like when you have a atherosclerotic plaque, this eccentric pattern of enhancement. And then you can see some wall remodeling here with a little bit of narrowing, but this is what a positive stroke causing lesion would look like. And so when I saw this figure, I emailed Dr. Fan, and at that time he was a physicist. He's a PhD. He's a physicist at Cedars-Sinai, and I wrote him this email that I'm really interested in your pulse sequence. I saw your paper, I read it, the images looked amazing, and would you be willing to share this with me? And so I emailed this email to him, and then he replied a couple of days later that he was very open to collaboration and that he could share a PDF with me. And so from that point on, where we had this beginnings of a collaboration, I actually flew to Montreal that year in 2019. I had never met him before, but I was so grateful and thankful And it was harder for me to fly to California, but it's easier for me to fly to Montreal. So just to give you some geographic information, I'm in Philadelphia, which is only about a 90-minute flight to Montreal, whereas it would be a 5.5-hour flight to Cedars-Sinai in California. And so I flew to Montreal for one day. I did a one-day registration with my sole purpose of meeting Dr. Fan in person to say thank you for sharing that with me. And so since then, I've built this program on the principles of these three ideas. So innovation, new tool, and then implementation, building an infrastructure. And I'll talk about how I did that using the RE-AIM framework, focusing on teams and processes. And then finally, integration, which really means value alignment with your institution, with the people that you're working with, and your network. So what is the RE-AIM? So RE-AIM is a framework in implementation science. It stands for reach, effectiveness, adoption, implementation, and maintenance. And so using this framework, I'll share with you step by step what I did to try to build this infrastructure and this program. So when I talk about reach is really about the patients that I'm caring for, right? And so before I do vessel wall imaging, I had to understand what patients am I targeting. And while it seems obvious, right, anybody with a CNS vasculopathy, I wanted to better understand in detail what vessel wall imaging was most applicable for. And so a student of mine, Samantha Geary, and I did this meta-analysis study where we looked at all of the articles in the literature that use vessel wall imaging and vasculopathies. Ultimately, meeting inclusion-exclusion criteria, we had 128 articles that she and I both read through each one of these to understand what types of diseases vessel wall imaging is most applicable for. And so in this pie chart, you can see that the vast majority of the studies looked at atherosclerosis, followed by arterial dissections, and then also vasculitis. So those were sort of the top three vasculopathies that vessel wall imaging was used for. I also wanted to know, well, which clinicians, right? As a radiologist, I don't contact the patients themselves. And typically patients are contacting the clinicians, right? The patient-facing clinicians, not looking at which radiologists take care of their diseases. And so it was equally important to me not only to understand the patients, but which clinicians, number one, are interested in vessel wall imaging and taking care of these patients. And so as a proxy, what I did was look at the journals that those vessel wall imaging papers were published in. And so these are the specialty journals that those papers were published in, and you can see the vast majority of the non-radiology fields is neurology, neurosurgery, followed by rheumatology and some scattered general medicine, ophthalmology, and ENT specialties. So this is my reach, meaning which patients and which clinicians who are taking care of those patients. That's my audience. And that was the first step in this foundational model to make sure I understood who's my target, since I'm not directly contacting those patients. The next step in this framework is about effectiveness, right? So even if I have an audience, they may come and leave, right? If you're giving a talk, they may come and be like, okay, this is not applicable to me. And in the first 5 minutes, they may leave. They're only going to stay if they recognize that this is effective, meaning that this is something that impacts what they're actually doing. And so this is probably the most important part of this framework. And I'm going to talk about how I addressed and measured effectiveness. So the first question as a radiologist is, does the imaging that I'm proposing to do, does it add value? And when you think about adding value, it's really about, is it making a diagnostic diagnosis, or is it going to change management? And for a radiologist, that really comes down to not the imaging, but your interpretation, right? So just because you do an imaging doesn't mean that the report that you generate is equivalent, right? So it really comes down to your expertise. And so what I very quickly realized then is that my clinical interpretation of the imaging findings is going to be the number one thing that's going to be most important for the clinicians to recognize that it adds value. So one of the main points here is that the outcomes is not the tool. It's not the pulse sequence. It's not the MRI scanner. And I'll circle back to this in terms of how this is applicable to low resource settings, because again, this is something that you can do. It's not necessarily the tool, but your expertise. So to address that, then I realized I can't just bring this new pulse sequence to pen. I have to know how to interpret it and provide that value. And what that means is then I have to understand the biomarkers. And so I did this meta-analysis. So at the time, this is sort of in the beginning of COVID, and our health system essentially shut down, right? We were trying to minimize patient minimize outpatient care. And so during this time, I had also a lot of time. And so a student of mine, Tanos Pavlo, at the time, he and I did this meta-analysis to understand all of the papers that specifically looked at atherosclerosis for vessel wall imaging in patients with acute stroke. So patient population, acute stroke, what are the features that I need to know about to be able to interpret this accurately? And from this analysis, what we found was plaque enhancement was a significantly associated biomarker with culprit plaque, wall remodeling. And what that is when you have relative preservation of the lumen, right? It doesn't look very stenotic here, but you see this lesion that's outwardly wall remodeling, which you would miss. You would not be able to see that on lumen-based imaging, such as a CTA or MRA. The other feature that was highlighted in our meta-analysis was surface irregularity. So what you might be able to appreciate here is along the juxtaluminal side, there's this irregularity, meaning, for instance, plaque rupture, right? And so when the fibrous cap of an atherosclerotic plaque ruptures and causes downstream embolism, you'll see this type of feature. The other thing that I recognized from that original meta-analysis looking at what kinds of vasculopathies are important is vasculitis. And so another student of mine, Nathan Arnett, and we also did the systematic review focused on CNS vasculitides and vessel wall imaging. And we tried to understand what are the types of vasculitides that are most relevant for vessel wall imaging. And by and large, it was actually giant cell arteritis, as well as primary angiitis of the CNS, and then also infectious vasculitides. So all of that to say, building clinical interpretation actually comes down to knowing what to look for, but also just practicing, right? There's just no shortcut. You actually have to do the work. And so some of you may know Malcolm Gladwell, who's a social psychologist out there, writes a lot of very well-known books, one of which is called Outliers. And in his book, he has a chapter about the 10,000-hour rule. And what I extrapolate from this is there's just no shortcuts. You just have to keep building your own knowledge base and educating yourself. And you do that by reading the literature, right? So as I shared with you, those systematic reviews and meta-analyses, this gives you an idea of the literature and the work that has already been done, right? So you understand what's been done, what has not yet been done, right? Those gaps in the literature, as well as what needs to be done. So in grantsmanship, when I'm writing grants and proposals for research projects and asking the government for money, these are actually the three things that they want to know. What has already been done? Is the question that I'm proposing something that needs to be done because it has not yet been done, the gaps and the unmet needs? And they're only going to fund my proposal if I highlight the fact that this is a need and this has not yet been done. They don't want to fund something that's already been done. And so this is helping to build that foundational knowledge. And so through those years, actually, these are some of the meta-analyses that I did, looking at all vasculopathies, looking at CNS vasculitis, the infectious and inflammatory type. I also recognized that I needed to understand more about the MR pulse sequence because it does need to be optimized, and there's a lot of techniques that can further optimize it, and I needed to understand that a little bit better. Also atherosclerosis, right? So you'll remember that atherosclerosis and vasculitis were the top two, in addition to dissection, that were most important for understanding where vessel wall imaging fits in, and culprit plaque goes along with that. And so you have to build the foundational knowledge. And then in addition to that, I just had to take call, right? So I worked a lot reading all of the vessel wall imaging cases at the time when the program was building. I also attended the multidisciplinary case conferences with the neurologists, and following up on their cases is when you learn the most. And so this is just here in the US, the way my department measures my work effort in terms of the radiology clinical care is by work RVUs. And so this is just to show you that there's just no shortcut. In addition to reading the literature, you also just need to do clinical work. And this is also because in the literature, they will show you, and actually, my lecture is probably the same. When people are presenting their work to you, they only show you the best pictures. But the reality is not that, right? The reality is, yes, you have some, great non-motion degraded, perfect looking images, but the reality is these are short cases. They're altered, they're moving around in the scanner, and a lot of the cases are motion degraded. And so you have to get comfortable with that spectrum of cases, and you only get comfortable with that by just doing the work. And so effectiveness in terms of building your clinical interpretation expertise also goes along with not just the foundational research, but also doing the work. And so once I do that, then I can start trying to measure my outcomes. And the outcomes is not equivalent to diagnostic interpretation. It's how my interpretation impacts patient care, right? Like it's hard for me to measure if my interpretation is good. That's just me talking to myself. If that interpretation is changing patient care, that's when you know you have impact. It's a little harder to measure, but this is how I did it. So the first easiest thing to do was just survey my clinicians. So a lot of the neurologists, neurosurgeons, neuro-ophthalmology, and rheumatologists, they order my vessel wall imaging exams. And I just asked them, how has this changed your clinical confidence for managing your patients? This was an anonymous survey so that nobody felt compelled to make me feel good. They could write whatever that they wanted. And fortunately, I was lucky that 90% agreed from their perception that vessel wall imaging actually helped change and manage their patients. So this was a positive sign. However, that's still an opinion. And what I want to know is it actually changing their practice patterns, right? They may have the perception and opinion that it's positive because it's new and it's interesting, but is it actually doing something for the patients? And so what I noticed over time is that vessel imaging actually got integrated into patient care. And the three most common ways they were integrated for neurology was that if a patient had cryptogenic stroke, meaning they have not found an answer for what's causing the stroke, and the patient just keeps coming back with 1, 2, 3 recurrent strokes, sometimes the question is biopsy for vasculitis. And so before this brain biopsy step is where I've noticed vessel wall imaging has integrated itself into that practice pattern. The other one is neurosurgery for angiogram negative subarachnoid hemorrhage. And then also we have a GCA fast track, and that's how it's been integrated. So I'll show you examples of each one of these. So cryptogenic stroke patients. So this is a case where we had a 58-year-old gentleman who came in with these cardiovascular risk factors, and he had this paramedian, right-sided paramedian pontine stroke that you can see on this diffusion-weighted imaging. On the time of flight imaging, there's no severe stenosis, right? The vessel looks fairly open and patent, and you might suggest that there's a little bit of irregularity here. However, the definition of intracranial atherosclerosis for identifying a culprit lesion on lumen-based imaging is you'd have to have at least 50% or greater stenosis. So it's very hard to come down as this being a cause of plaque. We did a cause of stroke. We did vessel wall imaging, and here you can appreciate on that same case, corresponding to that area of irregularity, there's this eccentric wall thickening and enhancement, which is very characteristic of those imaging biomarkers that I shared with you from the literature for culprit plaque lesion. And so what you can get is something called branch atheromatous disease. This is also called perforator disease. And so when you have plaque right here along the margin of the parent artery, so here would be the basilar artery, what will happen is it will occlude the flow in the distal part and also occlude some of the perforators. And so the pearl here is that non-stenotic, so plaque that is not causing severe stenosis, can actually be visualized by vessel wall imaging. And so this can also help come down and narrow down the differential diagnosis. And so for instance, you may not have to do a cardioembolic workup to identify the cause of stroke. So this is one strategy where I've noticed that vessel wall imaging was implemented. Here's another case example. This is how neurosurgery uses it for angiogram negative subarachnoid hemorrhage. So here's a case where a patient came in with this aneurysmal pattern of subarachnoid hemorrhage on the head CT, right? You can see the hemorrhage going along the sylvian fissures. On the CTA that was done, you don't appreciate any saccular aneurysm, right? You're looking for an aneurysm that may have ruptured, but it's negative. And so then here the next step is to do a diagnostic cerebral angiogram to see, are we missing any saccular aneurysms or a vascular malformation that may have ruptured and caused this subarachnoid hemorrhage. So this patient underwent these injections, and again, this was read as a negative study. So no intracranial aneurysm, no early venous drainage, meaning no vascular malformation that may have caused this hemorrhage. These patients will then go into the ICU since they have so much blood in the brain and be monitored for about a week before they undergo a second DSA. And so during that time interval, during that week, what they'll do is order a vessel wall imaging study. And these are not always easy to read because there's so much blood in the brain. But one of the things that I look for is enhancement, and somehow it's not, the CTA is just not as sensitive You may sometimes notice a little bit of this outpouching on the vessel wall imaging, and that in conjunction with the enhancement characteristic suggests that there's a ruptured aneurysm. And so when they went back for the second DSA, they actually was successfully able to identify that and treat it with a flow diverter. And so this is another way that the neurosurgeons at my institution will use vessel wall imaging. And it can identify blister or perforator aneurysms that otherwise remain negative, right, occult on the CTA or DSA. The third way that Penn uses vessel wall imaging is for GCA, giant cell arteritis. So this is a vasculitis, and one of the disease manifestations of GCA is that it will affect the scalp arteries and sometimes, very rarely, the ophthalmic arteries. And so because the risk for these patients is that they could lose their vision if their ophthalmic arteries are affected, the Penn Rheumatology Division, they've created a fast track program to identify these patients and screen for this disease process quickly. And so what I've noticed is at the stage where they're about to do clinical care coordination as a screening study, they use vessel wall imaging to see if there's any type of vessel wall enhancement of the scalp arteries. And you can see here, the primary care physicians, because a lot of these patients will present with headaches. They'll go to their primary care or family medicine, and then they'll be referred to the GCA fast track service, in which case the rheumatology division here very commonly recommend these GCA MRA protocols because there's a high negative predictive value. And so this is another way, a third way that these vessel imaging studies have been integrated into patient care, and I've noticed they're actually changing their practices. And so all of that together with high quality interpretations is where I realized that it is truly impacting patient care. And then finally, the most strongest evidence of effectiveness is, are we able to avoid more invasive procedures, right? So number one, I surveyed the clinicians. I got an opinion that it was positively changing their management patterns. Number two, I've noticed that their practice patterns are actually changing. And then number three, ultimately, what I wanted to know is, okay, well, are we minimizing patient risk? And so I did a very preliminary analysis, a 4-month analysis from June to September 2025, and identified retrospectively if the clinicians were documenting, before the vessel wall imaging, if they were documenting what they were going to do next, and if that changed. And so among 9 patients with pre-vessel wall imaging lumbar puncture plans, I was able to see that actually 6 out of the 9 patients avoided a lumbar puncture, right? And something that I didn't consider before is that, before you're going to stick a needle into a patient's back and do a lumbar puncture, if patients are on any type of anticoagulation, you need to stop that coagulation. So these are not trivial procedures, even though we think maybe lumbar punctures are bread and butter in our practice. For patients, it's a little bit scary. They might need to stop their plavix, for instance, and it's scary to hear that a needle is going to be, inserted into their back. And so I think the fact that 6 out of 9 of those patients avoided a lumbar puncture, to me, this was the most impactful effectiveness measure. The other thing I did was measure how many of those patients avoided a DSA, a catheter cerebral angiogram. And so among 10 patients that had pre-vessel imaging plans, we actually noticed that 50% of those patients were able to avoid a DSA. And so if you think about lumbar punctures and DSAs, this is very time consuming for a radiologist or a neurointerventionalist, right? There's time, there's also facility costs, right? The room cost, and then also the kit to do the LP, and then the cytology that you have to do after you get the CSF, right? And then there's potential complications. If you think about all of this and the fact that we were able to avoid just in 4 months, 6 LPs and 5 DSAs, I think that actually saved the institution and the clinicians a lot of time, which, as you know, time is money. And so this to me was ultimately the culmination of what I thought is the most impactful effectiveness information in terms of impact on patient care. So you can see over time, over the past 5 years, there's been a slow increase in the number of exams that are being ordered. And to me, all of this together is a measure of effectiveness and outcomes. The next part of this framework is actually adoption, right? And so adoption is influence, right? This is your social reach in terms of the people who are involved in the care actually changing their practice. So again, any type of change was originally met with a lot of challenge. The two people that are involved in trying to change and implement this new program was actually MR technologists. I think MR technologists is so important, and I could not have done this without them. But the technologists, they're key players in implementation, as well as the ordering clinicians who take care of the patients. And so first, I gave a lot of talks to the MR technologists because I wanted them to buy in, right, and adopt this as well, because they're the ones who are actually scanning the patients. And so what I needed to first do is make the process simple, right? Nobody's going to buy in when I say, oh, this is a really complicated process. And one of the main things that they care about is just getting the exams protocoled. And so what I did was create fit for purpose exam codes. And so the word vessel wall was specifically in the exam code, which then makes it easy, right? People don't have to dig into charts. They don't have to call you. They just see what was ordered. And then on the protocol interface for us, I also integrated that into our protocol interface so that, again, you see, vessel wall, then you can click vessel wall, the technologist sees vessel wall, and they don't have to pick up the phone. They can easily follow the words of what's been ordered. So I tried to make those workflows simple, right? And reduce complexity. And so the idea being the who, what, where, right? The clinicians put in the correct orders that say vessel wall, and then the neuroradiologists, we can select easily. We see that vessel wall, we can select the protocol, and then the technologist then sees the word vessel wall again, and then on their MR console there are folders that say vessel wall. So again, reducing the complexity by just making the name simple, right? Easy to read. Nobody has to pick up the phone. Nobody has to go into the chart and dig through, what the order is. This was one of my main goals to get buy-in and easier communication among the teams, including the technologists. Second, it's easier to get influence when people understand, right? So education was something that was important to me, even for the MR technologists. And so I gave one-to-one feedback to the techs. I did several 10-minute, short spiels during their staff meetings to help them understand what the technique was. And then I also created a website just for the MR technologists, right? Like this is just specifically geared to them with language that's helpful for them to understand. And so when they go to that website, there's protocols and tip sheets dedicated to the MR technologists for each of the different protocols. So giant cell arteritis, right? Because that's one of the commonly ordered exams. For the brain, right, I have the vasculitis as well as the subarachnoid hemorrhage. And then we also do some neck imaging for carotid plaque in particular, as well as dissection. So I did a lot of education and created tip sheets for the technologists. And then finally, I engaged them. I also asked them specifically, do they understand why the vessel wall MR imaging is being done and how it adds to patient care? Unfortunately, the MR technologists also agreed after all that education that this is something that impacts patient care. And once, we're all in medicine for the same reasons. We want to do the best for our patients. And so when they also understand how it's helping the patients, you get better buy-in, even if it's just a little bit more work. And so I would say those are the ways that I changed the perception of the MR technologists. The other stakeholder, right, is the ordering clinicians, the neurologists, the neurosurgeons. And those of you who are familiar with the literature, a couple of years ago, the ASNR, the American Society of Neuroradiology, did the survey to ask all the institutions in the US, what are some of the barriers to vessel wall imaging implementation? And one of the leading causes were actually the lack of clinician interest. And what that means to me is that they just don't understand it well enough. And so same concepts and principles, making workflows simple, educating and engagement is the same thing that I did with the ordering clinicians as well as the MR technologists. So again, with the ordering clinicians, they know what they want, right? So then I tried to make that ordering interface easy. If they just type in vessel wall, they should get this pop-up that says, do you want head or neck imaging? And then if they want head, they can choose, if they want to do a vasculopathy workup or if they want to do a subarachnoid hemorrhage workup. So I also recognize that for me to understand how to make their work lives easier, I needed to just ask them. I can't just assume, especially since I'm not putting in the orders as a radiologist. So I asked them, do you find it easy to order a vessel wall imaging study? Most of them said yes. There was a few that said no. And then I asked them, well, what could be improved? And so I surveyed them and I got 3 pages worth of comments. which, was a lot for me, but this also told me that they care. And I don't know if you've taken surveys, but typically, it's work and it's time to complete surveys. And so the fact that people are actually completing and typing in 3 pages worth of feedback to me meant that they cared. So I took that positively. And one of the things that I wanted to highlight of the comments that I received was that the current order set makes it way easier to order than prior iterations. What I want to highlight is there's prior iterations, right? So this was a work in progress, right? This took about 5.5, 6 years for me to do. And this wasn't a one-stop shop. I continuously improved upon it because, I got this kind of feedback. So that's something that I want to emphasize in terms of this adoption stage. I also did a lot of education with the ordering clinicians. I gave grand rounds to the neurologists, the internal medicine resident case conference, neurology fellows lecture, right? These are not radiology people. These are the ordering clinicians. So I thought it was equally important for them to understand what vessel wall imaging can do, as well as what it cannot do, right? I think the limitations are also equally important for them to understand. And when you get more education across the board, then you actually get more streamlined ordering and it just works more efficiently for everybody. And again, I want to highlight that what's important is not the tool itself, not the pulse sequence or protocol, but it's your interpretation, right? And so this is something that I want to highlight that you can do yourselves for any type of innovation. It's all about your education and expertise, less about the resources. You need both, I would say, but I really want to highlight that the interpretation matters. All right. For engagement, the way I approached this was, all those papers that I was writing, in addition to the case reports, there's the clinicians who are taking care of those patients. And so I included them on those papers. And so the people here that I'm highlighting in yellow are actually non-neuroradiologists or non-radiologists. They're people from neurology, they're people from ophthalmology, people from vascular surgery, right? So these are all of my collaborators. And the reality is also nobody has time to read, let's be honest. And so if you put them as co-authors, this is also one strategy to help them educate themselves, because if their names are on it as a co-author, they're more compelled to read what they're going to be a co-author on. And so this was a strategy for engagement, but also education in parallel. And the other thing I want to highlight is some of the residents here, both in neurology and ophthalmology, they actually are now attendings, right? They're faculty at other places, also here. Just an example, Wells was a resident at that time. He's now faculty, all of these people. And so the trainees are ultimately the future. And so once you start this process and they learn about it as a trainee, once they're practicing, they'll be the faculty lead positions to ask for and better understand this technology. And so over time, despite the barriers that were highlighted in that ASMR survey, for us here at Penn, I would say we have rising interest among our ordering clinicians, and this is not one of the barriers that I see here at Penn for implementing vessel wall imaging. All right, the last 2 processes, they kind of go together, but implementation and maintenance are the last 2 phases of this RE-AIM framework. So implementation. So one of the problems with new innovations is that you're actually introducing a new knowledge domain. So I can share with you that my neuroradiology colleagues, most of them did not have vessel wall imaging during their residency training, right? And so this is not something that my own colleagues are aware of. And so anything that has a new knowledge domain within radiology, that in and of itself is a barrier for adoption. And the problem with vessel wall imaging is that it addresses stroke patients, and stroke patients are 24/7. So I can tell you in the beginning, I was reading all of these cases because, I was the expert and I had the expertise to do that. But for me, even this becomes a challenge, right? It got to the point where it was difficult for me to take vacations without my laptop and reading cases if a inpatient or emergency case happened to come up. So this, as our volumes rose over time, this is something I had to address. Otherwise, I was going to burn out. Right. And so as the volumes rise for emergent care, I needed to very quickly educate my own colleagues so that I'm not the only person reading vessel imaging studies. And so I had to address neuroradiology workforce readiness, my own division. So the 3 areas that I needed to educate them in was, appropriateness, right, protocoling and ordering. And then for the MR techs, they'll call to ask for image quality checks. And then finally, interpretation. So how did I do this? Well, first, again, I went back to the website because I can't be around all of the time. And I created a tab on my website for how to ordering and protocoling. And so the way that this is organized, it's almost like a menu, right? So these are the types of vessel wall imaging that we do. They can click on the plus sign here, and then when you click on that, it'll give you like a one-liner indication what needs to be ordered, and then also how to interpret. So on that same page, just below, there's interpretation tip sheets. So for example, if you click on, vessel imaging stroke, it'll give you like a quick one-liner of which pulse sequences are part of the protocol. The pearls, right? I can't do everything. Nobody wants to read, a paper while you're on call, right? They don't have the time. So the quick highlighted pearls, as well as a quick tip sheet guide, is what I created and uploaded. Similar to the MR technologist, I did the same for the ordering for the neuroradiologist. And I gave a lot of lectures, both didactics about technique, interpretation, and pearls. Here at Penn, we have case-based conferences quarterly for the fellows, which the attendings can join. I also created the online tip sheets, as I showed you, and I made these very short. These are all free online, so you whoever's listening in this lecture can also go to that website and see all of the educational materials that I've uploaded. I created reporting templates to make it easier to highlight, pertinent positives and negatives. What are the checklist items that you should be evaluating? And then I also have a Microsoft Teams group. So for challenging cases or questions that come up, I created a Teams group for the relevant parties that they can peruse on their own, which goes into cases a little bit more in depth. And then, you can do all of this, but I thought the most impactful thing was actually have a small group of super users. So what are super users? So here at my institution, we have 30 neuroradiology attendings. We have a really large division. This is just clinical neuroradiologists. It's hard to train all 30 of my clinical neuroradiology attendings. And let's just be honest, some of my more senior level colleagues, they don't want to learn more. They want, change is a challenge. And so what I then did is also recognize that in my division, there's areas of interest, right? So we have people who are specifically interested in spine, specifically interested in head and neck, for instance. And so the few who are interested in stroke, I contacted them one-to-one. And I asked them, would you be willing to be a super user? And so fortunately, on any given time, one of the 7 of us would be around, or I guess it would be 8, including myself, right? And so I don't have to be on call all of the time. At least, even if there's a case on a weekend, on a Monday, there'll be at least one of the 7 of us. And so as a collective group, I can get support from the division to handle this acute stroke care. And I also measured their readiness, right? And so in the beginning, I asked them to take the survey about how confident or not confident they felt about evaluating appropriateness, checking image quality, and doing diagnostic interpretations. I distributed this to the faculty in 2023 and then again in 2024. And between that time, we had increased growth in our division. And then they can choose, how strongly they felt about their confidence. I measured this in 2023. As you can see here, this is all faculty, the red and the blue. And then I asked specifically just the super users, those 7 people. And fortunately, having more experience really helps. And so all 7 of those super users felt increased diagnostic confidence for assessing all 3 of these domains. And so this is how I addressed neuroradiology workforce readiness. The last stage of my implementation framework here is about maintenance and sustainability. Just because you start something, if it disappears after you leave, for instance, then you've had no success. That's how I believe. All this work would have gone to naught. And so maintenance and sustainability was really important to me. So the way that I see maintenance being addressed is actually the future. And that's all of you guys, the residents, the fellows. If you have one person who's the champion of your new tool or new program, you educate a couple super users and they get very interested in it as well. And then you have a division that's doing it, right? You're expanding this network. And then we have our neuroradiology fellows and also diagnostic radiology residents. And among all of these groups who get introduced to vessel wall imaging, if there's at least one new vessel wall imaging champion from this group, to me, that's success. And so here's an example of our current Penn Neuroradiology fellows. This is the current year. I surveyed them in the beginning of their fellowship. How comfortable do you feel about vessel imaging? And you can see they all feel a little bit mediocre because it's kind of a new thing. I will survey them again at the end of this academic year to see if this has increased, and hopefully it has. But the other thing I asked them is, how do you anticipate using vessel imaging in your future practice, right? Like when you go out there and graduate and get a new job, do you see that you're going to use it? And what I was surprised to see was that several of the fellows wanted to become the go-to experts. So this is my new vessel imaging champions. And so hopefully this is how you sustain and maintain the work. Also, there needs to be alignment, right? So among the individual stakeholders, which is the technologists, ordering clinicians, and neuroradiologists, if they see diagnostic value, this is going to stay. And then at the organizational level, right? So the institution, are they going to help support this, right? The division level and the department, if they see that it brands your site, right, and it's changing clinical algorithms and it's saving you costs because you're not doing the LPs or the or the DSAs, you know, there's education and research that comes along with it. This is all going to be alignment with the program and help sustain and maintain it. And that's when you get a Center for Excellence. So a little bit about research, and I'm almost at the tail end of the talk here, but when you start getting engagement education, you actually start building and developing research questions together. It's because you have the complex cases, the patients that come in that are complex, you're talking about it. As you discuss it together, you realize, hey, this is something that would be a really interesting research question. And so although one of the barriers that were identified on that ASNR survey was that nobody's really interested in research, I would say at Penn, this has not been the case. And we have rising interest in research collaborations with our clinicians. So if you recall, at the very beginning, right, this is how I got started, right? To develop this pipeline, I had nothing. I emailed somebody that I didn't know. I emailed him after I read his publication, and he very kindly shared his PDF with me. And since then, over time, Dr. Jiayang Fan and I have co-authored 12 peer-reviewed publications together during, you know, those last 6, 7, some years. And we also just submitted a grant last February. Hopefully it'll get funded, but we shall see. And so this is how it all started. And I think over time, this is how things can really develop creatively. And so the messages that I want to share with you is that leadership is actually what implements innovation. It's not the actual innovation tool. The first thing you need to do is think about building the infrastructure, and what that is about is standardizing, training, and measuring. That's the reach and adoption stages, right? It's the leadership that builds systems. You're not building a service. You're not a service line, right? You're trying to build a system in place. You have to engage your stakeholders, right? You can't do this alone. You have to do it with others. And to do that, you simplify workflows and you educate and you empower. That's the effectiveness and the adoption. And so what you're doing with the leadership is really building trust. And then finally, you want alignment, right? If you want something to stay, implement, and maintain, you have to show that it's impactful. You have to show that it's efficient and that it's sustainable. And so what that is you're building for the future. And so you have to have that foresight in place. And some of the lessons that I learned from this process that I want to share with you in Nigeria is that it's not so much about the tool, right? You don't need, you know, a very high spatial resolution pulse sequence or something that's very expensive. The way that you build a program, and this is really applicable for anything, these are just principles that I think I learned from this process that I wanted to share with you that you in Nigeria can do too. Innovation is social, right? You really need relationships. Advocacy is really important. And what I mean by advocacy is all of that engagement and education. And that's how you start building coalitions, right? This is your research and adoption. It's a very social process. And when you think about it that way, it's really about crossing boundaries. You're not within radiology yourself. You're talking to the MR technologists, you're talking to the clinicians, the different subspecialties, and you need to cross that boundary. Second, if you're focused, right, that will build credibility. If you do too many things all at once, you're going to be scattered. But if you really have a narrow focus, that builds trust and credibility. And it's easier to simplify if it's a focused question or effort. You'll have to measure, right? People can't take your word for it. You'll have to show some outcomes, and then you just empower the people that you're working with, right? And so effectiveness and adoption is about focus and building trust. And then finally, I think I've highlighted multiple times in my talk that education is actually so key. It's part of that infrastructure. And education helps build those pipelines, both the research pipeline, clinical pipeline, patient care pipelines. It will, once you have a pipeline in place and you have that reiterative process, you'll learn to be more efficient. And when you're more efficient, it will help with sustainability. And so it's really about being forward looking when you're trying to educate everybody around you. It's not just about what you can do, because actually alone, it's just impossible. And so what I wanted to highlight again is innovation does not implement itself. It's about leadership and how you measure those, or how you conduct that leadership by emphasizing being social, coalition building, credibility, and education. And so what started out as, a challenge, right? Because I was trying to introduce change over time that led to what I believe is success. And with more people and, again, that social factor, that's what will help you sustain that success. Some of this work has already been published in AJNR, right? So if you're interested in reading a little bit more detail, the RE-AIM framework was published in this implementation study, and then the education for neuroradiologists was reported in this brief report in AJNR not too long ago. This just came out, I think, in January. So thank you very much for listening. That brings me to about 7 minutes in the hour, and these are all the people that I need to acknowledge. Including, I think the technologists are very often forgotten, but they have been so key in this process. I really appreciated their support and help, and I would not have been able to do it without them, as well as my clinical collaborators. But I think somehow the techs are in the background, so I really wanted to bring them to the front. I have a lot of acknowledgements for the group of them, because there's so many. If you have any questions, I would be happy to answer them.
Thank you. Thank you very much for that very well given lecture. So many insights from the practical things that you are doing over there, and we really appreciate. I don't know if there's any question. Does anybody want to ask any question? When I saw maintenance as one of your one of the frameworks, I was wondering, because most times when we hear maintenance here in Nigeria, we are thinking of the equipment, like the MRI equipment, where in this LMIH, you have limited access to the hardware and maintenance supports. Are there frameworks that would help us to, to make it more available to us, the technology and of that vessel wall imaging, and even maintaining of the infrastructure in our own environment? And there are things that you could suggest that could help us with that. I know you talked about collaborations and all, but are there things that could help in maintenance of the infrastructure?
Sure. So what I can share with you is that I actually did not have a tech, like a physicist support system here at Penn. That was something that I looked really hard because it would have made my life so much easier. But I didn't. The physicist that I worked with is in California. It's very different, right? He can't come to the MRI console and help me. And so what I did was actually get the support of the MR techs. Because I didn't have an interested physicist here at Penn. And so, if you have an MRI scanner, naturally, you're also going to have a technologist. And so that's the strategy that I used. And I think you have that. If you have an MRI scanner, you have a technologist. So, and correct me if I'm wrong, but you should have that person or resource available to you. So the challenge there is trying to, everybody is very busy, right? And so the challenge then is asking the technologists to make extra time, which is a challenge that I faced here at Penn too. They're all really busy. It's not part of their job description. Why should they do this? And so, as I mentioned, when I was trying to do the adoption stage, I said trying to make processes simple, but also the other two principles that I used was about education and engagement. So I was around, right? Meaning I taught them, right? I didn't just say, can you do this and follow the protocol? I said, can you do this? And this is why, right? I treated them as a peer and educated them about what we're doing. And so once they understand, they get more interested, right? This is sort of human nature. And so that is actually how I got the program up and running, because I didn't have an on-site physicist to help me. And I think a technologist, if you have a hospital system, they're readily available and they're there. It's just trying to persuade them to make that time for you. And I strongly believe, probably not everybody because, they're busy, but if they have a little bit of interest and they understand why and how it impacts patient care, right? As I mentioned, uh, we're all in medicine to help patients, right? And so if you kind of tell them, this is really actually helping the patient that you and I are taking care of together, right? Then they're more inclined to be part of that workflow and process. I guess the one other thing I would mention is not just at the time of imaging, but even after. Oftentimes I think what happens with the techs are that we only call them when there's a problem. I mean, this happens at my institution. We call them and say, hey, like what's wrong with this protocol or this imaging, why is it so motion degraded? Or we call them and say, hey, did you forget to send this one of the imaging sequences? Or so generally I feel, thinking about it from their perspective, we only communicate with them and call them when we need them because there's a problem. And so the other thing that I did was not just at the time of imaging, but even after, if I came to a diagnosis, I communicate to the clinician, like to the neurologist, but I actually also looped in the MR technologist who scanned that particular patient. I showed the findings, maybe take a quick snippet. And I said, this is the positive finding of the patient that you helped scan. And I thanked them. And I said, thank you for, being part of this patient's care. Like together we came with a diagnosis. And so, this makes them feel good. And also, it's true, they were part of the patient care. And so, this was the other part of getting engagement from the MR technologists who otherwise, right, in the beginning, they told me, this is not part of my job description, don't bother me. So, and that's actually the truth. Not all of them, but some of them were like, we're all busy. And so I understand from their perspective too. So that was a long drawn out answer, but to go back to your question about basically infrastructure and resources in terms of expertise, I used what was available to me. And what was available to me here locally was actually the clinical MR technologist. I did not have a dedicated physicist working with me on site. The one thing, as I mentioned, that I did get from the dedicated physicist was a simple PDF, right? So he kindly shared a PDF of the parameters. And then I asked the MR clinical technologist here at Penn, here's the PDF. Can you help me, put in the parameters and match this? So I got a lot of help from actually the clinical MR techs. So again, the question about resources and the people for infrastructure, I think if you recognize what you have available and then try to work with that maximally, again, innovation is about actually so the principle being about being social and coalition building and having a team. Everybody has expertise, including the technologists. It's your job as a leader to go and try to persuade them to be part of your team. So that's how I would answer that question, because that is in the beginning I felt constrained by the lack of a physicist as well, but I was able to work around it.
Yeah, thank you. Thank you. That's leadership. And you said innovation does not implement itself, that leadership does. So these qualities that were exhibited that's leadership. So thank you. Thank you for those insights. Um, so the neuroradiology division, are they made up of just radiologists? Do you have other people in other subspecialties like maybe internal medicine, surgeons that are not radiologists? Do you have other people that are not radiologists in your neuroradiology division?
In my neuroradiology, no. So in the neuroradiology division, we're all radiology trained. Maybe I didn't understand the question. I mean, I work with the neurologists, rheumatologists, neurosurgeons, but they are in a different department. So they order the imaging, and then the imaging is interpreted by the neuroradiologist. So we're in different departments, and we're not. We have different expertise. Does that answer your question? Or
Okay.
maybe I didn't understand.
Yes, yes. I wanted to know if there is collaboration from people that are not only radiologists.
Yeah.
Thank
Well,
you.
so in terms of collaboration, I guess what I would say is they see the patient. I don't see patients. Patients, just as an example, if I had a disease, what I would do is I would probably Google who's the expert in my disease. And what will come up is actually not a radiologist, right? It will come up with,
Mm,
for instance, a neurologist with expertise in disease, X, right? I rarely ever see if a patient just Googles, who's an expert in my disease or who's an expert in my cancer. It's almost never a radiologist. It's actually the clinician, right? And so they see the patients and then they refer them to me for like vessel imaging. So that's the that's the clinical collaboration and flow. It's not, patients are not messaging me or calling me to say, Dr. Song, I have this disease. I think probably patients don't know who I am. And that, that's part of radiology, and I'm okay with that. I know that's some people think that as a specialty may be a drawback, but I'm okay being in the background a little bit. And
yeah,
the patient care comes through the clinician, so that's the collaboration and workflow.
yeah. Thank you. Thank you so much. Thank you so much.
Okay,
It's been a
great.
wonderful time. Insights are great. Any other question or comments? Okay. I believe we have had a wonderful time. In the absence of any other question or comments, I guess we'll call it. We want to first appreciate Dr. J. Song for spending this wonderful time with us. It was a great topic, and the implementation framework was also a great insight. Thank you so much for
Yeah.
being with us. Thank you
Yes.
so much.
Thank you.
Yeah.
Thank you very much.
Jay, thank you so much. It was lovely lecture. Thank you, at least for giving us a framework for leadership. And I love the part that you talked about building collaboration and sustainability. Thank you so much. Looking,
Thank you, Godwin. See you soon in May. Looking forward to it.
looking forward
Bye,
to
everybody.
yeah, bye.
Bye.